Good morning. It's my pleasure to welcome you to Atkinson Hall, home of the newly named Qualcomm Institute, the UCSD division of Cal IT2. It's quite a mouthful, California Institute for Telecommunications and Information Technology. But I want to take a few minutes to share with you the larger story about what this institute stands for, how it connects technology with applications in health. So we were set up about 13 years ago explicitly to promote science and innovation. So we are part of a collection of 4 of these institutes. And from the very beginning, it was a private-public partnership. The state provided funding that paid for the capital costs, but the research program really came together through our partnerships, essentially with all the companies that you think of in the telecom sector, as well as in the years that followed with the major funding agencies, NSF, NIH, that began to see how significant information technology was in terms of redefining the conduct of research and practice. So it's been an interesting journey. We've gone through 2 major downturns, but we are still around, and it's a very dynamic place. The focus today is on direct observation therapy, so I thought I would use that to share with you one example of a project from a few years ago to give you a concrete sense of how we have interpreted this mandate to innovate and to connect technology with applications. This is a project that I'm familiar with because I was personally involved in it. This was in the context of stroke therapy. It was a program called Stroke Doc. Dr. Brett Myers and Pat Leiden at the time, and I and others partnered to create a mechanism by which you could remotely diagnose if a victim who was presenting themselves at a remote clinic was someone that one might prescribe RTPA to, the clot-dissolving drug. So we had an early version of the HDR system. This is one of the few audiences where I can go into both sides of the story. We had an early version of the HDR, high data rate systems, which went on to become the EVDO. Right here in the Jacob School on top of our building. So we had a base station, experimental. We had about 600 kilobits per second, all for ourselves. And so we were able to build a system where we used that cellular connection to be able to do video examinations. The first prototype we put together, we had Brett and Pat take a look at it. They said, don't bother. This is no good. So it was a wonderful early lesson for us in what it means to work with folks from the medical school. They're very quick to give you feedback on what works and what doesn't work. They were not impressed with the demo. Why were they not impressed? Because the video was too jerky. And if you really dig down into the kind of tests they do, you're asking the victims to do things like raise their hand and drop it, and if it does this because of video jitter, that you confound with neurological diagnosis. So as engineers, we said, so what can you throw at the problem? And they said, well, a few seconds delay won't hurt. So it really came down to rebuilding the codec so you could trade off jitter for latency, right? So that's what we did, and at the end, there was a clinical trial for which we received a few $1 million of funding from NIH. And again, I think folks in this audience might appreciate it. So we did a side-by-side test, and we actually had a publication in Lancet Neurology. And here were the 2 branches. You had Brett and Pat, the experts, talking to a general practitioner at the remote end on one branch over a telephone link, just voice. On the other branch, voice and video, right, using our system. And the efficacy on the voice branch, voice alone, was 85% compared to what an expert how they would diagnose. And on the video side, video plus voice, it was 98.5, right? So we actually have what we think is the first publication that demonstrated the value of video in doing remote diagnosis for a very specific condition, which was actually quite demanding. So to me also, it's an example of how we could push on all frontiers. The engineering part of it wasn't just grab something that's available on the website somewhere and plug it in. We actually had researchers. We had a small local business spun up by one of our faculty that played this role. Pat even managed to get reimbursed, so the billing aspects of it. So it was a great example of how to create value. So I'm delighted that we have this opportunity here today. This is a fantastic gathering. I guess I'm the designated speaker here today, but I want to recognize Dr. Brenner, Vice Chancellor of Medicine, has the entire hospital system as well as the medical school. And I think it's an exciting time. There is almost $1 billion worth of construction going on the East Campus, a new medical tower, the Jacobs Medical Tower, new opportunities to explore how technology might be infused more effectively into these kinds of environments. We have Steve Relia here, our Vice Chancellor for External Relations and Business Affairs. So he both brings in the money and decides how to spend it. So if you want to talk about in-building distribution systems, so we can have ubiquitous wireless connectivity, he clearly is the person. Richard Garfein, it's been great to sort of work up the partnership. I think Phil Rios is here in the room, Kevin Patrick. So we really mingle multiple disciplines here. I could go on, but I think that we should really hear the specifics of this particular program. So thank you again and welcome.
Well, thank you. I would just like to echo what Ramesh said about the amazing work that's going on here. I used to think that the School of Engineering was all about building machines and sending astronauts to the moon. But when you actually walk the halls here and you look at the scientific posters that the students and the graduate students are putting together, they're all about these really cool devices that are being implanted in human beings or measuring things that people are doing. And there's really a lot of connection between healthcare and engineering going on at Cal IT and the Qualcomm Institute. So I appreciate the opportunity to be here. So what this project is about was an idea that came from working with our county health department. I'm a public health guy by training, and I look for problems and I try to find solutions. And when we had a possible solution, I looked around and I said, where can I get help with this? And I went to my colleague, Kevin Patrick, who's also in the School of Medicine but has a joint appointment here at the Qualcomm Institute. And he said, I know the programmers. So we put it together. So what I'd like to do is tell you a little bit about what we have discovered and what we built and what our next steps are. And the first thing I'd like to do is start with my collaborators, because I know I'm up here on stage, but there's a lot of people that have been supporting me, and I really appreciate everybody's help, including my staff from the School of Medicine who've been on the field with me, the programmers here at Cal IT2, Fred Rabb, Phil Rios, Allison Flick, David McCarter, and others, and our health department colleagues both here in San Diego and in Mexico, and especially our funders, which started out with the National Institutes of Health and has moved on to the Verizon Foundation. I am really grateful for the support and to see so many faces here that I now get to know in person. So let me tell you a little bit about tuberculosis. It's an airborne infectious disease. It's transmitted from person to person through coughing or singing or sneezing, and it's ubiquitous. It's all found all around the world, although the prevalence is much higher in certain countries, including South Africa, Asia, India, Eastern Europe, and parts of Central and South America. A third of the world's population carries the bacteria that causes the disease of tuberculosis, and in fact, it's one of the most deadly infectious diseases in the world. There's 1.1 or 11.1 million current cases of TB worldwide, and there's 8.8 new cases of tuberculosis every year worldwide, and it results in 1.4 million deaths. Bringing it a little closer to home, in the United States, we have just under 10,000 cases per year, and the good news is that it's dropping. The case rate in the United States is dropping because of the hard work by the health departments around the country to make sure the patients are diagnosed and effectively treated. In the United States, the incidence rate is 3.2 per 100,000 population, which compares to about 200 in countries like India. But in California, we have about double the incidence rate that we do in the rest of the country. And in San Diego, we have an even higher incidence rate of 8.1 cases per 100,000. And California has the highest incidence rate of the continental United States. And then there's 4 states, and you'll notice most of them are along the border or have large immigrant populations. California, Texas, New York, and Florida each have reported over 500 cases in the last year. And the 4 states combined consist of over half of the TB cases in the United States. So these are important areas that we need to be working in. The good news is that tuberculosis is curable. most cases of TB can be cured within 6 months with taking antibiotics, but adherence is critical. If the patient doesn't take their medication consistently and completely, the disease can come back, the patient doesn't get better, they can continue to transmit the infection, and drug resistance can develop. Drug resistance is a huge problem, and it's not just a problem for tuberculosis. Many other infectious diseases also have the ability to mutate and form strains that are resistant to the antibiotics. And when that happens, the antibiotics that we use to treat the patients no longer work, and we have to come up with new drugs, which I guess is good for the pharmaceutical companies because then they have more business. They have to keep developing new drugs, and they can sell them at higher prices. But currently, there's 58 countries around the world that have reported cases of what's called extensively drug-resistant TB, which is basically a form that is almost untreatable. So we're going back to the pre-antibiotic era with these infections. Also, when you have drug-resistant TB, you need to treat with second-line drugs that are more toxic, less effective, and it increases the time of treatment from about 6 months to up to 2 years. And these resistant strains can then be transmitted to new patients who then start with a disease that is not treatable. So what are the things that contribute to poor adherence? These are things like it's a long treatment regimen. It's 6 months. I know when I get a prescription for 10 days of an antibiotic, I take it for about the first 4 or 5, and then you're like, do I really need to take the rest of this? Imagine if that's now 6 months. There are side effects of the medications, some of which are very lethal. They could be hepatotoxic. They could cause liver damage. And the treatment takes a long time, and the patient usually feels better within the first month or 2, and now they're being told they need to take pills for another 4 months. So it's very hard to get patients to be compliant. So the solution that many health departments have come up with is what's called directly observed therapy. And this is literally just watching the patient take their medication every day. And this could either be done by a DOT worker going to the patient's home and watching it take place, or the patient could be required to come back to the clinic to pick up their medications, which is more of the model that occurs outside of the United States. This method is recommended by the Centers for Disease Control and the World Health Organization because it's been shown to work. It improves adherence, it reduces the risk of acquired drug resistance, treatment failures, and relapses, and it also decreases the number of doses of medication that the patient has to take. So when you're talking about something that's hepatotoxic, it's better that you don't have to treat for as long. But there are problems with directly observed therapy. It's expensive. You have to have people that can do it. It requires transportation. It's impractical for patients that live far away from the health clinics. There has to be coordination between the patient and the provider. Both people have to be at the same place at the same time. And it restricts patient mobility. The patient has to be there when the DOT worker arrives. Plus, there's problems with the patient feeling that their privacy is being invaded or that it's stigmatizing. TB is a notoriously stigmatized disease, and patients don't want their neighbors to know that they have TB, and their neighbors might question why somebody's coming to their house every day. And basically, patients feel patronized. Why do you need to come to my house to watch me take my pills? So our health department here in San Diego has come up with some innovative ways to try to overcome some of these problems. And one of them was an experiment that they tried in 2004, where they used these landline-based phones, and they gave one to the patient, and they kept one back at the health department, and they would go through an interaction with the patient by phone, and they'd basically watch it the same way we would use Skype today. They did this with over a 9-month period with 33 patients, and they found that they were able to save 27,000 miles of travel and 800 hours of manpower, which translates to about $25,000. And that's only a tenth of the TB caseload at that time. So it seemed to be working really well. Now, and it's still being used today, if I'm not mistaken. The problem is that the technology's old, and they can't replace these devices anymore. They're becoming obsolete, and a lot of patients don't have landline phones anymore. So we said, well, maybe there's another solution. And at that time, when I was talking to Kathy about this, I looked at my own kids, and they're on their phones all the time, and they have no problem sending videos to each other. So I said, why do we need landline phones? Why can't we be doing this with mobile? So that's when I approached Kevin Patrick, and I said, is there a way that we could do this with some of the programmers that you have at Cal IT2. And so we thought about the idea. We proposed this to the National Institutes of Health, and we got funding for a pilot grant to do what we call mobile phone-based video directly observed therapy for tuberculosis. And what I want to do is I'm going to show you a very short clip just to kind of give you like a snapshot of what Video DOT looks like.
Video DOT is a mobile phone-based system for implementing directly observed therapy for patients with TB. Video DOT allows TB patients to be observed by a healthcare provider over their mobile phone instead of having to take a trip to the clinic. Patients simply record themselves taking their medication.
7382, I'm at home this morning. I'll be taking 2 rifampin, 600 milligrams.
And video is sent through a secure connection where it is viewed by a healthcare provider. The provider then documents the event at a fraction of the time and cost of in-person DOT.
3 milligrams of pyrazidamide, 3.5 pills.
So that's it in a nutshell. So how does that actually work for the patient? Well, what we've done is through our collaboration with Cal IT2, Phil Rios, the programmer who's developed the methodology for transferring the videos, came up with a solution that would work on our mobile phones to capture video and transmit it securely. And we do this with smartphones. And basically, he's developed an application that goes on the phone. And it's very simple for the patient. They just have to press one button to start a recording. And there's a green button that starts the camera. And the patient would just take their pills, show each one, go through the interaction. The whole thing takes about a minute. And then they stop the camera. And there's a little status bar on the phone that actually shows that the video is being uploaded. Now, while this is happening, the video is being encrypted, and it's being sent to a HIPAA-compliant secure server, which now we're using the Verizon Terramark cloud computing system for all of our data storage. And it goes to a secure website that Fred Rabb and Allison Flick have programmed, so that the DOT worker back at the health department just has to go to this website. I have to learn how to spell my name. See, it's very secure. It won't let you log in. Okay. And it logs me into a website where if I'm the DOT worker sitting back at the health department, I can find the patient that I'm looking for, who's patient number 1. And in here, I could enter information about the patient. I could also set up the patient's medication schedule and review it if necessary, modify it. But then I could come over here to the video screen, and it shows me a list of videos that have been sent, and I look at the most recent one. And as you can see, there are fields here where I can record information about the video. And the patient would just take their pills, show each one, go through the interaction. The whole thing takes about a minute. And there you go. So as quickly as that, the video is sent to the health department. Now, the nice thing about this application also is because it's a recorded video, it's not live, the patient can do this before they go to work. They could do it in the middle of the night. And they could do it when they're traveling. They don't have to be at home. The other thing is that the videos actually get stored on the phone and they get held there until the patient is in a Wi-Fi or a cellular area. If they're not, say they're traveling deep in Mexico and there's no cellular signal, the videos sit on the phone until they get back into a place with coverage. Then the videos automatically get uploaded. The patient doesn't have to do a thing. Okay. Now, in order to train the patient so that they know what to do, the DOT worker gives them a little bit of training on how to use the phone. We've also provided them with some educational materials to explain how the process works. And so that's video DOT in a nutshell. So we pilot tested this in San Diego and in Tijuana, and I just want to show you very briefly what we found. So we did a study to look at the feasibility and acceptability of video DOT. We recruited uncomplicated TB patients, 18 years and older. They all signed written informed consent. And a TB caseworker trained the patients on how to use the phone. And we conducted a little survey before and after to find out how the patient felt about the experience. And we did this for between 4 and 9 months for all the patients. They were on treatment for that long. And so here's the results. We enrolled 43 patients in San Diego and 9 in Tijuana. There were 6 patients actually that are binational, which is a big problem here in San Diego, is that we have a lot of patients that travel. But I just want to point out that we have patients as old as 86 years old that were doing it. And then we have a good mix of racial, ethnic, and gender in our population. So here's the really exciting finding for me. We found that of the videos that we were expecting to receive, in other words, the doses we needed to watch being taken, 93% of all the videos that we were expecting arrived in San Diego and 96% in Mexico. It's actually better on the more recent end because we learned in the process how to do a better job with the technology. Also, we asked patients if they had problems recording videos, and the majority said that they rarely or never had any problem recording videos. The nice thing also was that if they had to redo their treatment, they said they would prefer to do it with video DOT. And we asked if they would recommend it for other TB patients, and 100% on both sides of the border said yes. And so now I'd like you to just hear really quickly what one of our patients actually said. This is a gentleman who was found out that he had TB. He was quarantined by the health department in his home until he can start treatment. And he started out with the traditional DOT, and then he switched to video DOT. And this is his experience. Oops.
We had to schedule nurses to come in and watch me take the pills. It was very chaotic, very tough to schedule people. Everybody had different workloads. And then one day I'm taking it at 8 o'clock in the morning, and the next day I'm taking it at 1 o'clock in the afternoon, or I'm taking it at 7 at night. VDOT was available where you set it up, and just like taking a home video or Skype, that I would sit there and, take the pills so that they could see them. They had to be able to see it. They had to see my face and my mouth, and they had to see it actually put in. It took about 10 minutes to be taught. I had a little nice program put together so that I could refer it initially, and I would say within the first day I was able to use it. Putting the pills and everything together and waiting for someone to come and see me take it usually was about 30 minutes to 45 minutes of my time, and there too, because they had to set up, they had to lay out and that. As soon as we switched to the video DOT, the first month I would say it was taking me about 2 minutes, 2.5 minutes. By the time I got to the very end of the program, I was able to do this thing in about a minute.
So we're very grateful to have this patient be willing to speak. Again, TB is a stigmatized disease, and oftentimes people don't really want to talk about it publicly. But we've heard the same story over and over. And if you talk to my staff, Fatima and Kelly and Jasmine, they'll tell you that these are the stories they keep hearing from the patients. So we think this is a nice solution. So where do we go from here? This is where I am very grateful to the Verizon Foundation for their support. When we told them about what we were doing, they said, "This is great. We'd really like to be able to help you out." And so with a small grant from the Verizon Foundation and a very large in-kind donation, we said to them that what we need to do is we need to take the prototype that we developed for this pilot, we need to scale it up. We need to make sure that it's partitioned out separately so that we can have multiple TB control programs using it simultaneously, and their data is all secure and protected from each other. We also needed to update the application on the phone to make sure that it would work on multiple different phones, not just the ones that we actually were piloting with. And Phil Rios has done an excellent job with that and that integration. We also needed to, we said, if we're really going to scale this, how do we do this easily? We could either buy a computer here and build it out of our computer, but then if it gets big, we need to buy more computers. And we turned to Verizon, and they said, use our Terramar cloud computing service. And by using this, we're able to build the system within the cloud, and then as it grows, we just expand it out. And so it's a very nice, flexible way of being able to store our data and build it in a way that it would be scaled more quickly and more flexibly. And so what we've done this now, we've accomplished that. Our database and web interface that you saw have been updated by Allison Flick and Fred Rabb and David McCarter, and we're ready to launch this in new cities. And so San Diego is our first test site. We're going to be enrolling 50 new patients in San Diego to try out the new system and see how it works. And we've already been working with New York City and San Francisco. We're just going through the process of getting all the approvals so that we can start them as well, and there'll be another 50 in each of those cities. What we see is that from our experience working with the 2 health departments already is that health departments have a difficult task, and it's hard to change. And so modifying the way of doing business is sometimes a slow process. So by receiving phones and service and support from Verizon, we're able to offer this to the health departments sort of as a seed to say, here, try it out and see how it works, with the hope that they're going to see the benefit and be able to start adapting this to their programs. And as more health departments see how this is working, they'll say, hey, there's evidence now. It's not something that we're just going to try, but there's actually empirical evidence to show that this is an effective way to do it. And so that's sort of the combination of business and academics, where we want to make sure that we're developing things rapidly and scaling quickly, but also having the evidence behind it to say that it's effective and that we can make policy around it. So thank you very much. Now we have another speaker who was supposed to be here today, Dr. Bustamante Moreno. He's the Secretary of Health for the state of Baja California. And Baja California has the highest incidence of TB in all of Mexico, and they sit right below us here in San Diego. Their incidence rate is about 5 times what it is here in San Diego. And he saw VDOT, and he saw how it worked, and he was excited about it, and he's been pitching it to the national health programs in Mexico City. And he's there today, so he wasn't able to give the speech in person, but he recorded it for us, so we're able to hear his experiences with VDOT and his appreciation for the project. So.
Muy buenos días. Realmente me hubiera gustado mucho estar ahí con ustedes en esta presentación de un proyecto innovador que gracias al doctor Richard Garfield se ha estado trabajando en ambas partes de la frontera. Baja California y California debe verse como una región en donde es un área endémica para la tuberculosis, y Baja California, con la tasa más alta de incidencia y mortalidad, es preocupante y hemos invertido una cantidad importante de recursos. Sin embargo, el impacto no es el que hemos deseado. Para esto, con este nuevo proyecto innovador, estamos buscando empresas socialmente responsables que nos ayuden, que a través de un sistema de celular podemos nosotros abarcar, atender y curar al paciente con tuberculosis. La migración es un problema que hemos estado trabajando nosotros, pero también el impacto que queremos en salud no es el deseado aún. Yo quiero agradecer a la empresa Verizon por el interés que tiene a través de la Universidad de San Diego de este proyecto innovador, porque Baja California, sobre todo Tijuana, tenemos la tasa más alta de incidencia en tuberculosis y la mortalidad. Y con este plan piloto que ya manejamos y que vemos que es viable y de alto impacto, estamos seguros que vamos a dar un paso muy importante en la salud pública de los baja californianos y también de los que viven en California y que vienen también constantemente a Tijuana. Por eso yo quiero agradecerles y también invitarlos a que nos apoyen, tanto a San Diego como a Baja California, para desarrollar este proyecto. Nosotros seguiremos buscando también en México, ya lo presenté en la Secretaría de Salud Federal, para seguir este camino que para nosotros como región queremos realmente implementarlo con la garantía que va a ser viable y positivo para el enfermo. Yo quiero agradecer al doctor Richard Garfield, a la empresa Verizon y a los medios de comunicación, que es parte importante siempre en la salud para poder difundir todos los programas. Y con este plan piloto estoy seguro y convencido de que vamos a hacer una cuestión positiva en la salud pública. Gracias y felicidades a todos. Enhorabuena.
So the beautiful thing about being here in San Diego is that we have the ability to have these cross-border international relationships. And because TB and other infectious diseases don't respect borders, we need to be working on both sides. So we're thrilled to have the collaboration with Mexico as well. So the next person I'd like to introduce is Dr. Kathleen Mosier, who's the Director of TB and Refugee Health for the San Diego County Health and Human Services Agency, who's always been an innovator and always been willing to work with outsiders and to be flexible and to try new things. And I think because of that, we're able to come up with innovative solutions quickly and experiment with them here in San Diego. And our TB numbers are dropping, and I think it speaks loudly to the effect of the kinds of work that Kathy does. And so I appreciate having a partner like you to work on this project with. Kathy?
Thank you, Richard. Richard and I met, do you remember? Over, actually in Tijuana, over tamarind martinis. Yeah. They're very delicious. Anyway, it turned into a very good partnership. And I'm really excited to be here today. I really like the fact that we have government together with the academic center like UCSD and with corporate partnership to bring forth like this very nice project. It's very exciting. I've worked at the county for many, many years, and I do want to say that I'm very happy to work at the county where they really promote innovation and effective partnerships on behalf of our patients. So I really feel fortunate for that. Directly observed therapy is an integral part of TB care. And although not every program puts every single person on observed therapy, we do in the County of San Diego. So we have about 200 to 300 new patients a year. And everyone is either on DOT through their whole time on treatment or at least in the beginning. And we have this strategy, as do many other places. Just it's hard to pick and choose who, you can guess who might not complete treatment and be adherent, but sometimes it's hard to be sure who will be adherent. So we don't want to be in the position of picking and choosing. So really it's a universal policy. And what it does is we can be sure that people are on the right medicine for the right length of time at the right dose. And it's very easy for people to pick up prescriptions you may have yourself and you just get the wrong dose, you know, when you pick it up at the pharmacy. So being there and the next month you may get the wrong dose or even the wrong medicine sometimes. So being there and knowing that right dose, right time, right length of treatment is very important. The other thing that directly, and the whole point of it is not only to get them to be cured, and cured in the shortest period of time, but it really is also about drug resistance. The way you develop drug resistance is to take your medicine in the wrong way, the wrong dose, and you actually, basically natural selection, you select out resistant organisms. And in the world today, there's about 500,000 people who have drug-resistant TB, and every year there's more and more resistant strains. So we don't want that to happen here. We don't want it to happen in our cross-border region. So DOT is the way. What I think we're seeing now is like an evolution of directly observed therapy. And what I think we're getting to is where we're going to find a menu of options. One size does not fit all. So for some people, face-to-face is really what will work for that person. Some people, especially, TB is an airborne infectious disease, so they're isolated, some people for months. And so for that person, the DOT worker going to their house is kind of nice for them. It's the only person they're seeing. Some of the older people, they're really, my mom has an iPhone now, they can get with it. But for some people, it's hard technology. And they like the face-to-face and talking to the outreach worker. So we're not going to get away from face-to-face. People who have drug-resistant TB, they're on injections. We've got to work on that, how you do that over the phone. So that's going to be there. Our funny, I call it our George Jetson phone, but that was, I have to say, Washington State started those, picture phones. And still, some people have their landline and like their landline and are comfortable, and it's real time. So you can talk to the person if they're having side effects. So we have about 10, 15 people in that, so that may be a solution for some people. But really, of course, where it's at is these mobile technologies. And so I think, it's a great step forward, and all the younger people who have TB, they ask us, why can't you do this on a cell phone? Everyone can do everything on a cell phone. So now that we can do the videotape and send it in, not only do the patients like it, what great flexibility. We have a lot of people who do DOT, but they work, 7 to 5. And this allows people to take it early in the morning, allows them to take it late at night, and to travel. So people, 6 months, 2 years of treatment, people travel, people go on vacations. So this allows them to go on their vacation, and we have to work out, cell phone towers and those kind of things, but we've already seen that flexibility. And we have people who actually are cross-border patients. They work on this side of the border. Maybe they have insurance on this side. They have Kaiser insurance through work, but they live for a variety of reasons on the other side of the border. So when they're sick and can't be at work, how do you do that DOT? Well, with this kind of technology, it's perfect, to do the DOT cross-border when they travel. So it's really been a great step forward. The other thing is that Richard's right, it takes a while not only to change, budgets and, start paying for this and not paying for that, but also to change people's minds. The patients got onto it a lot faster, but sometimes, we're used to seeing them face-to-face. And public health people do worry, what happens when I'm not there in their house? That doesn't feel good, because we've never done that. And so this kind of, with the George Jetson phone, the next step, and now these phones, it's gotten, I wish my staff actually was here today because they're doing most of the work, but they would actually say, we love this. There's some problems once in a while, we work through those, but really the patients love it, we love it, and they're getting used to it little by little by little. We're also seeing that we will be able, when we really ramp this up, we'll be able to redeploy staff. So now we have, 8, 10 people who do a lot of DOT driving around town. Well, they'll be able to be redeployed to other things, education, prevention, screening of high-risk populations. So we're looking also forward to the day when that can happen. And then finally, for pure prevention, there's a new treatment course that is out there for prevention. So that's when you have infection, you're not yet sick with TB, and we try to prevent you from developing TB. So it used to be that you would take 9 months of daily treatment. And no TB program really had the resources to do directly observed therapy for all the people on prevention. So you took it on your own. Then and nobody basically finishes 9 months. It's very hard to take on your own 9 months for prevention of something you don't have. Then it moved to a 4-month, but it's more expensive, and still 4 months is hard on your own. Now, for about the past year, there's been a CDC recommended treatment of 12 doses once a week for 12 weeks, and that's prevention. Except because it's hard to remember to do things once a week, who can remember to take medicine once a week, and because the study was done where they did it observed, it's recommended to do it through DOT. And so TB programs are trying to figure out we're already busy, how do we also do now prevention with DOT? And so an application like this is not only for treating but preventing the future cases. So it really has a lot of applicability, and we look forward to working with all of you to make this be all over the U.S. and internationally. So thank you very much.
Good afternoon, everyone. I think I've had a chance to meet most of you, but for those who I haven't had a chance to meet, my name's Gene Ng, and it's a real pleasure for me to be here today on behalf of Verizon. And I'd also like to take a moment to recognize some of my colleagues who are here today as well. So if I can ask all my Verizon colleagues to stand up. And I didn't want to embarrass them by calling them out by name, but then I'd probably forget a name or two and then feel bad about it. And I'd also like to thank each and every one of you for joining us today to announce the launch of our partnership with UCSD, because at Verizon, partnerships like this one are just part of our commitment to social responsibility, which is embedded in the way that we do business. And that's why we're using our advanced technology And we're partnering with dynamic, forward-thinking, and forward-looking organizations such as UC San Diego to improve healthcare outcomes. And our focus is really on underserved communities, those patients who face the greatest challenges in managing and treating chronic healthcare conditions and getting access to quality care. And our goal is to ensure that all patients receive cutting-edge technology solutions that can help address their individual healthcare needs. And through Verizon's innovative healthcare initiatives, we're able to seed innovation by providing our wireless, broadband, and cloud technologies through an in-kind giving model. And through this social innovation, we can help accelerate the rate at which the next generation of healthcare information technologies reach each and every patient. So we're pleased to be working with UC San Diego to scale the impact of the innovative VDOT model, which you saw today, and the impact that can have both across the country and around the world, potentially saving millions of dollars in public health care costs. But I think more importantly, by partnering together and leveraging technology, the power of technology, we can increase both the quality of and access to healthcare, thereby improving the lives of thousands of people. So again, thank you for joining us here today.
That's a wrap. We're actually, we're going to be retiring out to the foyer. There's some refreshments out there. I did just want to ask, were there any questions that anybody would like to ask right now, or we can go out and I'm happy to answer questions. Personally, we've got my staff who've been on the boots on the ground, deploying the VDOT, Jasmine Cuevas, Fatima Munoz, Kelly Collins, and our economic analyst, Dr. Jose Luis Burgos. Our programmers, Phil Rios, Fred Rabb, Allison Flick, and I'm not sure if David's here or not. Kevin Patrick, my colleague, partner in crime. We're here to answer questions, but is there any pressing question that anybody would like to ask right now? Oh, okay, well, and I don't want to stand between you and the refreshments, so we'll see outside.